All right, well, welcome back, everyone. We'll now have Dr. Mary Wells introduce our next speaker.
All right, thank you. So this is another very exciting topic. It comes up basically weekly in Tumor Board is what do we do with the surgical management of a clinically positive Axilla. And so Dr. Abigail Cottle is here today to talk with us about updates in management of the Axilla. She is the breast surgical oncologist at the University of Texas MD Anderson Cancer Center, where she is currently the Vice President of Procedural and Therapeutic Medicine. She earned her MD from the University of North Carolina at Chapel Hill and continued graduate studies at the University of North Carolina, Chapel Hill, and the University of Texas MD Anderson Cancer Center. She also holds a master's in clinical research design and statistical analysis from the University of Michigan. Her research has focused on adaptive surgical techniques as well as dissemination and implementation of clinical research. She's received several awards, including the MD Anderson Cancer Clinical Innovator Award in 2015, and she's considered a pioneer of the targeted axillary dissection procedure. So thank you, Dr. Cottle, for being here today. We're all very excited to hear what you have to teach us.
Thank you so much for inviting me. I'm going to try to share my screen. Let's see if this works. Let's see. Let me get you back over here.
Oh, we can.
Can you see it?
Yes, we can.
Okay, let me just get it close to my camera so I can see it and see you. So I want to thank you for inviting me. You know, there were actually several presentations and posters at San Antonio this year dealing with the axilla, which is exciting for surgeons because a lot of things at San Antonio are very medical oncology driven. We don't get to be featured a lot in the presentation, so this is a pretty exciting year for us. I have no disclosures relevant to this talk. So let me tell you a little bit about what we're going to talk about today. First, I want to talk some about the clinically node-negative patients and management of sentinel node positivity. There were several posters related to that. Also, what we do in patients over the age of 70 with ER-positive tumors. Obviously, that's been also an area of a lot of debate over the last several years. Then we're going to transition to clinically node-positive patients. I'm going to give you a little bit of background about how we manage that, the trials to date related to that, and the whole concept of the CLIPS node, because there were several presentations and posters related to marking lymph nodes and ensuring removal and how to do that and does it help. We're going to talk briefly about outcomes with omission of axillary lymph node dissection. And then I'm just also going to touch briefly on the impact of responder. Obviously, that's a medical oncology trial. But I don't know about you, but that has really impacted what we're doing in our clinics. We still have a lot of debate about it. In fact, we've scheduled a multidisciplinary meeting in about 2 weeks for everybody to get together and talk about how we're going to incorporate responder into our clinical practice. So let's start with a clinically node-negative patient. One of the trials presented in the poster sessions and was actually highlighted in one of the poster spotlight sessions was SINODAR-1, and this is a trial out of Italy. To give you a little bit of background, we know that ACOSOG Z11 showed no benefit to axillary lymph node dissection in patients who had clinically T1, T2 tumors, who had 1 or 2 positive nodes undergoing breast conservation and whole breast radiation. You've heard about that a lot over the last 10 years. However, there are a few unanswered questions from that trial. One is that 70% of those tumors of the patients enrolled in the trial were actually clinically T1s. 40% had micrometastasis, and over 90% received radiation. So we don't know how to incorporate that in patients who've had mastectomy. So SINODAR-1 was established to enroll patients with T1 or T2 breast cancers. They could have mastectomy or breast conservation therapy. And they had to have 1 or 2 sentinel nodes with macrometastasis, so over 2 millimeter metastasis. And they were randomized to axillary lymph node dissection versus sentinel dissection alone. This is the data they presented. In both sides, about 80% had breast conservation therapy, 20% mastectomy. So still a pretty small number with mastectomy. We still don't have a great answer on that question. But remember, these are all patients with macrometastasis, and when you look at their outcomes at a median of 30 months, you see that in the sentinel node group, they had 1 axillary recurrence, 3 distant recurrences, 1 death, and then 1 non-breast cancer, compared to sentinel node and axillary lymph node dissection, which had no axillary recurrences, 3 distant relapses, 2 deaths, and 3 non-breast cancer. This gave a 5-year cumulative recurrence of 4.9% for the sentinel node arm versus 6.5% for the axillary lymph node dissection arm. So what are we going to do with this? So this was a poster. So obviously things presented in poster, we only had a glimpse of the data, and we need to wait for sometimes for manuscripts to give us a little bit more of the complete picture. But some take-home points for this one is that one, it's short follow-up. It's 30 months. And so we know that patients with small ER-positive breast cancer, we really need to follow them for a longer period of time to truly capture the recurrence rate. But it does show that it's safe to omit axillary lymph node dissection with macrometastasis. Now, let me clarify, all of the patients in this trial had a preoperative ultrasound and were clinically node negative, even with an ultrasound. So they excluded patients with ultrasound node positive disease in the study. And obviously that's also a point that has been debated over time. It also adds to the collection of data that omitting axillary lymph node dissection in these patients might be safe with mastectomy. Small numbers, like I said, when we get the manuscript, we'll have a little bit more data, but we keep sort of patching together data from different trials looking at that population of patients. There were several posters highlighted in the poster session looking at what everybody is doing. I think when we have these debates and we go to tumor boards, we all come up with what our group is doing, but then I think at meetings, and unfortunately we haven't had this experience this year, we're all asking each other, what are you doing? How are you incorporating this? And so there were several posters looking at that question. So this is one from the Michigan Radiation Oncology Quality Consortium, and basically reviewed over 8,400 patients from 29 facilities in a statewide database that's maintained in Michigan. And they looked specifically at patients undergoing post-lumpectomy radiation between the years of 2013 and 2019, excluding patients who had DCIS, neoadjuvant chemotherapy, or N2 or N3 disease. And what they looked at was that they looked at the radiation field to determine what kind of radiation planning people were using. And you can see it's a little bit all over the place, but they divided it by node negative and node positive patients to report who received nodal radiation, and if they did, what fields were added. They did a multivariate analysis, and they found, first they looked at node negative patients, and they found the use of regional nodal radiation was increased with adjuvant chemotherapy with an odds ratio of 2.7. Higher T stage, not terribly surprising as we get to the T3, T4 stages, patients were more likely to add regional nodal radiation, even in the node negative patients. No axillary surgery, so no sentinel node performed, actually had a pretty high odds ratio of 14.5%, indicating that if a sentinel node dissection wasn't done, radiation oncologists felt like they needed to treat the axilla in some way. Now, to be honest with you, I don't understand this next one. These are node negative patients, and they listed patients who had an axillary lymph node dissection. Obviously, sometimes with databases, it's hard to get the real information, so I'm a little bit wary of that data point. But also, patients who are treated at an academic institution were more likely to receive regional nodal radiation. They then pivoted to look at patients who were node positive, and specifically with N1 disease. And once again, found the use of regional nodal radiation was associated with many of the same characteristics. So the use of adjuvant chemotherapy, a higher T stage, an actual lymph node dissection performed, probably indicating a little bit more volume of disease. And then also if they received the radiation at an academic institution. This trial, this was performed by a Canadian group. This is another trial that was highlighted in a poster session on axillary management. Elaine McKivitt presented data looking at the use of sentinel node dissection in patients with ER-positive tumors over the age of 70. So background on that is obviously that the SSO recommends against routine sentinel node dissection for patients over the age of 70 with ER-positive breast cancer. But we know that over 80% of surgeons are still routinely doing it. So this was a retrospective review of 2,600 patients over the age of 70. 663 were sentinel node positive, and approximately 2,000 were sentinel node negative. They compared the patients who were sentinel node negative to the ones that are sentinel node positive. So in this patient population, one of the reasons for doing a sentinel node dissection that is often mentioned is that, well, it will help us guide our adjuvant therapy, because if they were sentinel node positive, we might consider adding adjuvant chemotherapy. And what you can see from their data is that even in the sentinel node positive patients, it was very unlikely that those patients would receive chemotherapy. Only 16% received chemotherapy. The majority had endocrine therapy alone, which was also seen in the negative sentinel node group. So what they showed is doing a sentinel node, not doing a sentinel node probably doesn't impact chemotherapy, even if the node is positive. What they did see was that patients who were sentinel node positive did have different radiation plans. So you can see in the sentinel node negative group, 42% had no radiation, 56% had just breast and chest wall, and only 2% had nodal radiation added to the radiation plan. But when you look at the positive sentinel node group, only 29% omitted radiation, 14% had it limited to the breast and chest wall, but 57% had nodal radiation added to their treatment. So this does show that the information given by the sentinel node did change radiation plans. The question is, does adding radiation really add a benefit to those patients? And so in their trial, they showed that having a positive sentinel node was associated with more adjuvant therapy, not a big surprise. But when they looked at breast cancer specific survival and multivariate analysis to see what actually benefits those patients, endocrine therapy had a hazard ratio of 0.51%, so indicating that endocrine therapy helps, and you could see that that was equally distributed amongst their sentinel node positive and negative patients. Grade 3 had a hazard ratio of 4.09, so also not a huge surprise. The sentinel node status, the use of radiation, or use of chemotherapy did not impact breast cancer specific survival. So really leaves us unsure. So we know that doing a sentinel node in these patients leads to more adjuvant therapy, but we don't know if that adjuvant therapy actually helps. And so the question is, are we over-treating these patients? And we still don't have answers to that. They did create a nomogram to help aid in those decisions. And if you're interested in looking at that nomogram, it's available on the San Antonio breast site. And hopefully they'll have the publication out soon so that people can see that nomogram and possibly use it to determine, when you see a patient, is this someone we should add a sentinel node dissection for, or can we safely omit it? This was another poster that was presented on a similar topic. This was Priscilla McCullough from University of Pennsylvania. And they did a retrospective study of 15 hospitals in the Pennsylvania area. They looked at clinically node negative women over the age of 70 with an ER positive breast cancer. And basically their primary endpoint was look at the outcomes after sentinel node dissection and radiation. And what they found was that this population of women had a very low rate of sentinel node positivity, about 11.5%. But they also found that there was low local regional recurrence rates with or without radiation. With radiation, the local recurrence rate was 2.6%. Without radiation, it was 0.5%. Retrospective review, so there's obviously some clinical bias in this and who they chose to radiate or not. But just another data point to help us as we are looking at this question. So I want to transition now to clinically node positive patients. And I want to give you a little bit of background and sort of tell you the story of the clip. So we know that knowing the nodal status is actually one of the most important aspects of multidisciplinary planning. determines the need for chemotherapy and radiation, which can alter reconstruction plans. We also know that physical exam alone is unreliable, has a false negative rate of about 45%. So there's been a lot of interest and discussion about using ultrasound to evaluate lymph nodes, biopsying lymph nodes when they look suspicious, and using that information to guide therapy. We know that in clinically node-positive patients, neoadjuvant chemotherapy is often used. We're going to touch a little bit on responder at the very end because this may change how we approach some of these patients. But in patients who are clinically node-positive and receive neoadjuvant chemotherapy, 40 to 70% of them will convert to lymph node negative with neoadjuvant chemotherapy. There's been a lot of interest in using sentinel node dissection to determine which patients have converted to node negative and might not benefit from extensive axillary surgery. But that's really been limited by a very high false negative rate. And what I mean by that, the false negative rate is in those proportion of patients who have residual nodal disease. What proportion would have been missed by looking at sentinel node alone, meaning the sentinel node showed no cancer, but if you had removed the rest of the lymph nodes, you would have found cancer. Why do we want to avoid axillary lymph node dissection? Well, up to 70% will have some morbidity after the operation, including pain, limited range of motion, or the one that obviously we all dread is lymphedema. So if we can avoid doing that in patients who may not need it, we want to find a way to do that in a safe manner. So there were 3 trials published several years ago looking at sentinel node dissection in clinically node-positive patients after neoadjuvant chemotherapy. The SABCS2021 trial from the US, Sentina from Europe, and SNFNAC from Canada. They all had similar trial designs. They enrolled women who were clinically node-positive. They got neoadjuvant chemotherapy. At the time of surgery, they asked surgeons to perform a sentinel node dissection followed by completion axillary lymph node dissection. So this allowed them to compare the pathology of the sentinel nodes to the other nodes and determine a false negative rate. One of the amazing things to me is that 3 trials done from different parts of the world all had incredibly similar results. And so the SABCS2021 trial has set up a pre-specified success threshold of 10%. They would allow a false negative rate of 10%. However, what you can see is that all 3 trials exceeded that threshold with false negative rates of 12.6 to 14.2%. What they also all showed was that surgical technique matters. So all 3 trials showed that using dual agent mapping technique reduced the false negative rate significantly. Taking out more sentinel nodes seemed to be beneficial. And then adding the use of immunohistochemistry also helped improve the accuracy of identifying patients who were truly clinically or pathologically node negative. The 1071 trial had a small subset of 170 patients who had a clip placed in the node after the biopsy. And if that clipped node was retrieved as a sentinel node, the false negative rate dropped to 6.8%. This makes sense. If you want to know if the chemotherapy got rid of the cancer in the lymph nodes, it makes sense to look at the lymph node that you knew had cancer to begin with. Similar to the way we put clips in breast. If we want to know if the chemotherapy eradicated disease in the breast, we like to make sure we saw the clip in that breast specimen to know that we got the area that we knew had cancer. One of the trials that we did at Anderson was we established a registry study because we wanted to know what happens to the clipped node, and is the response in that clipped node reflective of what's happening in the other lymph nodes after chemotherapy. So we asked our radiologists to start placing a clip in the lymph node when they had performed a biopsy and it showed cancer. Those patients went on to get neoadjuvant chemotherapy, and at the time of surgery, the axillary lymph nodes were removed, and we asked the pathologist to state the pathology of the clipped nodes specifically so that we could compare it to the other nodes. In our first publication on this, we had 191 patients, 120 were pathologically node positive. And when we looked at that clipped node alone, we had 5 false negative results, which gave us a false negative rate of 4.2%. Now, you can imagine this is pretty exciting because remember the 1071 trial and these other trials said they would accept a false negative rate as high as 10%. So a false negative rate of 4.2% was encouraging. But we wanted to know, is that better than sentinel node alone? There was a subset of patients, 118 patients, who had a clip node, they had a sentinel node performed, and they had a completion axillary lymph node dissection performed. So we could compare the pathology of all three sets of those nodes. And in 74 patients who were pathologically node positive, we found a false negative rate of 10.1% with sentinel node alone, so very similar to what those three trials showed. But if we added evaluation of the clip node, we reduced that false negative rate to 1.4%. Why is that? Well, the CLIPS node is not retrieved as a sentinel node in about 20 to 30% of cases. In our trial, it was 23%. You can see some trials from other parts of the world that also show pretty consistent results with that. And I'm going to show you in a few minutes two other recent trials that once again are showing very consistent data on this number. The SABCS2021 trial, remember the clip node was a sentinel node in 63%. It was definitely not a sentinel node in 20%. And in 17%, we don't know where that CLIPS node was. So that led us to think, can we selectively remove that node? Because what that shows us is that if we had relied on sentinel node alone, we would have missed looking at the lymph node we knew had cancer to begin with. So looking for a way that you could selectively remove that, we created targeted axillary dissection, which basically means that at time of surgery, we remove the lymph node with known disease, or the one with a clip in it, as well as the ones most likely to have disease, or the sentinel nodes. And the way we did this initially was using an I-125 radioactive seed. We placed it 1 to 5 days before surgery under ultrasound, and then used the neoprobe to remove that CLIPS node that had the seed in it, as well as the sentinel nodes. In our first publication on TAD, what we call targeted axillary dissection, we had 85 patients, 50 were pathologically node positive, and we had 1 false negative result, which gave us a false negative rate of 2%. Now, there have been several groups that have looked at this in very small numbers until recently, because one of the concerns was the data I just showed you was a single institution, large volume institution, and is this really replicable in other places? And so what you can see are some of the early results. So Pittsburgh was using I-125 seeds as well. In Spain, they were using intraoperative ultrasound to identify the CLIPS node. The Dutch group, and I'm going to show you their recent trial, but their first trials had something called MARI. So they basically placed the radioactive seed in the node at the time of biopsy before chemotherapy. The patient kept the radioactive seed in their node throughout chemotherapy, which is something that we can't do in the US because of regulations, and then removed it at the time of surgery. Their first publications did not add sentinel nodes, so they were just looking at the CLIPS node. And they showed a false negative rate for the clip node alone of 7%. And then Stanford, and now recently several institutions from Korea and the UK have been using carbon black suspension to tattoo the node. Now, this is a recent trial called the CENTA trial, and this was a prospective registry trial using 50 centers in Germany. They included patients who had biopsy-confirmed nodal disease, a clip placed in the most suspicious node, who received neoadjuvant chemotherapy. Now, because of regulations in Germany, they can't use radioactive seeds, so they used wire localization. And basically, their goal was to evaluate TAD in a real-world, multi-institutional setting. This is a bit of a busy slide, but let me just sort of walk you through it. They had 473 patients who were clinically node positive and received neoadjuvant chemotherapy. A pretty significant proportion of those, they couldn't see the clip node on ultrasound through chemotherapy, so they didn't attempt to localize it. In 423, they did attempt to localize it, and 329 of those were successful. So about 78% of the time they were successfully able to localize that clip node. A lot of that was because they could not see the clip on ultrasound. Out of that subset, 203 patients had an axillary lymph node dissection so that we can really assess false negative rate. And what you can see is in the 111 patients who are clinically node positive, there were only 8 false negative results looking at the clip node alone. So that gave them a false negative rate of 7.2% for evaluation of the clip node alone, Once again, we're all showing very consistent results on the false negative rate of that node. Remember, they also really wanted to look at TAD. And TAD involved not only removing of the clip node, but also the sentinel nodes. So they had 77 patients who had TAD procedure and axillary lymph node dissection so that they could assess the false negative rate of targeted axillary dissection. 46 were pathologically node positive with 2 false negative results. So that gave them a false negative rate for targeted axillary dissection of 4.3%. Once again, the clip node was a sentinel node in 63%, which means it was not a sentinel node in a pretty substantial proportion of patients. Because they had a multi-institutional trial, they really could look at some technical factors associated with failed localization, and they found that institutional experience matters. The centers who enrolled over 20 patients were 89% successful in localizing the clip node compared to 69% in lower volume institutions, suggesting a learning curve to the technique. And I will say that's on the radiologist side and the surgeon side. This has really been an evolution of learning how to do this technique, and it's really involved some multidisciplinary work. There were overall false negative rates they reported, sentinel node alone of 24%, the clip node alone of 7.2%, and then targeted axillary dissection of 4.3%. We and a couple of years ago, we asked the American Society of Breast Surgeons, and I'm just sort of saying this because there was a lot of debate at San Antonio about, do you have to add the clip? Can we just do sentinel node with best technique? Do we really have to add the clip? Because it does add extra procedures for the patient. So we did a survey of the American Society of Breast Surgeons a few years ago to ask them about some of these trials. We wanted to determine, 1, are surgeons familiar with the trials? 2, if they are, how have they incorporated those results into practice? And then to identify issues that contribute to non-acceptance of the trial results. We found that 45% of the respondents said they offered sentinel node to at least some clinically node positive patients after neoadjuvant chemotherapy before the trials, compared to 85% after the trials. But when we asked them, what do you think are the critical techniques to the accuracy of this, 82% said placement of clips and biopsy nodes with ensured removal. So I think many of us feel that this is a vital part of assessing the axilla after neoadjuvant chemotherapy. At the time, 2/3 were placing clips. Of those, 71 were trying to localize them for removal. The majority were using wire localization, probably because radioactive seeds do have a lot of regulatory burden. And at that time, there weren't a lot of other products available. One of the things that we saw in the San Antonio poster session is many people showing different techniques using RFID localizers, magnetic seeds, carbon suspension. So I think this has been an evolving area. So one of the trials presented at San Antonio is the Dutch group presented their RISIS trial. Remember, I told you about their Marian procedure where they were placing the radioactive seed before the patient started chemotherapy. With the RISIS trial, they're doing that technique, but at the time of surgery, they add sentinel node dissection. And so Janine Simons presented their work related to this. Here's the trial design. Once again, patients with clinically node positive disease, they have an I-125 seed placed in the biopsy node, go on to receive neoadjuvant chemotherapy, and then have that marked node and the sentinel nodes removed at the time of surgery. It's a non-inferiority validation trial, and they enrolled, they had 227 evaluable patients. So in patients undergoing the RISIS procedure, there were 144 who were pathologically node positive. Actually, lymph node dissection was performed in 135 so that they could really look at the false negative results, and they found 5 false negative results. That gave them a false negative rate of 3.47%. So very, very encouraging. When they looked a little bit at the technical aspects, in 84% of the patients, a sentinel node and marked nodes were retrieved, and 16% either the sentinel nodes or the marked nodes were retrieved. Now, this was a plenary presentation, and we don't have more granular data on that. So once the manuscript comes out, hopefully we'll get a little bit more information on which side of that they were having trouble identifying. So when they looked at patients who had residual disease, in 81%, both the sentinel nodes and the marked nodes had disease, but in 19%, either the sentinel node or the marked node had residual disease, indicating that both are important if you really want to improve the accuracy. And once again, the marked node was also a sentinel node in only 71% of cases. They had 5 false negative results from 5 different institutions, and 4 of 5 of those were early within the institution's learning curve. And when you look at the volume of residual disease that would have been missed, they missed a micromet in 1 patient and then macromets in 4 patients. So in summary, the RICES procedure showed a false negative rate of 3.5%. It shows advantage of marking nodes in a multi-center trial. I think the take-home points of this, we would all love to have a way that we can mark that node with a definitive marker that allows us to leave it in through chemotherapy and then proceed directly to surgery without putting the patient through another procedure. Unfortunately, the radioactive seeds are not going to be a way to do that in the U.S., but there are several ongoing trials, including one we have at Anderson called the Magellan trial, where we're placing magnetic seeds in nodes. But there are other trials looking at other ways to mark that node before chemotherapy. A couple of trials presented in the poster presentation I just wanted to go over. One, this is from Anna Weiss and the group at Harvard Dana-Farber. And they wanted to know, how often does the clip node impact therapy? So they looked at patients who had a clip placed after biopsy. All of these patients received neoadjuvant chemotherapy. Now, this subset was interesting to me. These are clinically node negative patients. So these are patients who had a biopsy, but the biopsy was negative. But the radiologist placed a clip in the node, and they decided they wanted to make sure they removed it at the time of surgery. So small subsets in this, but 34 patients, that clip node was not a sentinel node and 64%. Not surprisingly, if you removed more lymph nodes, you were more likely to get the clip node in your specimens. They had 9 pathologically node positive patients, and none had a positive clip node with negative sentinel nodes. So very, very small numbers. I don't know that this will impact my clinical practice yet. If a radiologist biopsies a node and they're really suspicious, even if the lymph node, the pathology was negative, sometimes at Anderson, they will place a clip and I usually remove it just to make sure that we get that node and have a good look at it. In clinically node positive patients, once again, the clip node was not a sentinel node in 20%. If you removed more nodes, you were more likely to get the clipped node. And then they had 58 patients with residual disease. So once again, small numbers, but one of those patients had a positive clipped node and negative sentinel nodes. So that's the patient that you would have missed the residual disease looking at the sentinel node alone. One of the big debates in this area is that we don't have oncologic outcomes. So we may know that we can accurately and reliably assess whether the patient has had a complete pathologic response to chemotherapy, but there have been no trials randomizing those patients to completion axillary node dissection versus no surgery. So while we're making this assumption that it's probably okay to leave the rest of the lymph nodes, there is no data to support that. And that's something I think it's really important to counsel patients on when you're talking about the possibility of omitting axillary lymph node dissection. So this is a poster that was highlighted in the poster session. It's from Andrea Barrio at Memorial Sloan Kettering. And they looked at clinically node positive patients who had negative sentinel nodes after chemotherapy. And a couple of caveats to that. At Memorial Sloan Kettering, they don't routinely clip nodes or require that they are removed. But they did in this trial require that at least 3 sentinel nodes were removed and that an axillary lymph node dissection was not performed because they wanted to look at the outcomes. They had 234 patients meeting the criteria at a median follow-up of 35 months. and they had one axillary recurrence, and that was in a patient that had refused radiation. They had a 4-year distant recurrence rate of 6.1%. So this is, I think, some nice data that shows that we may be right in that you can safely omit an axillary lymph node dissection in those patients. Once again, I think we'll get more data once the B51 trial comes out. That's a trial that's enrolling clinically node positive patients who get chemotherapy and have negative sentinel nodes or negative nodes after chemotherapy. In that trial, they are stratifying by patients who have sentinel node alone versus completion axillary lymph node dissection, and they're randomizing them to regional nodal radiation or no nodal radiation. So I'm hoping we'll get some data from that trial to help guide us. In the last few minutes, I want to talk about some trials in progress. This was out of Switzerland, tailored axillary surgery with or without axillary lymph node dissection, followed by radiation therapy. So this is a randomized multi-center trial. Their target accrual is 1,500. Tailored axillary surgery for them is basically removing any palpable nodes, any sentinel nodes, and then performing an X-ray to confirm clip removal. Now, in this trial, they do not require that you try to localize the clip node. However, they had a second poster that they did present looking at attempts to localize that clip node, and they found that image-guided localization was successful in 82% of cases. And they found when you used image guidance to remove that clip node, fewer nodes were removed than if you use non-image guidance. So meaning if you're doing sentinel nodes and you want to make sure you get the clip node, I think some of the people who did not have localization may have gotten a few nodes, then an X-ray, hey, we don't see the clip node yet, take out a few nodes, more nodes, do an X-ray till they found that clip node. There's also the ATNEC trial. This is out of the UK. They have a target accrual of 1,900 patients, and they're randomizing patients with node-positive disease who convert to node-negative after neoadjuvant chemotherapy. And they're randomizing similar to ACOSOG 11202. They're randomizing them, but a little bit different. So ACOSOG 11202 is randomizing those patients to axillary lymph node dissection and regional nodal radiation versus no further surgery, but getting regional nodal radiation. ATNEC's taking it a little bit of a step further, so they either get axillary lymph node dissection and radiation, or they get no axillary therapy, meaning no further surgery or axillary radiation. That trial does require that the biopsy lymph node is removed. So those are ongoing trials. They hopefully will have those results over time, maybe at the next San Antonio in the next year or two. I'm going to touch briefly on responder because I don't think we can talk about axillary updates and axillary management with at least talking about the conversations around responders. So I'm sure this has already been presented in your session, and obviously was a trial we were all very curious to see the results of. So here's the schema. These were patients with ER-positive, HER2-negative breast cancer with 1 to 3 positive lymph nodes. And I'm going to be sure we clarify, we don't know how that was diagnosed, but they were pathologically positive lymph nodes. Axillary staging by sentinel node or axillary lymph node dissection. In patients who had a low oncotype recurrence score, so 0 to 25, they were then randomized to chemotherapy followed by endocrine therapy or endocrine therapy alone. And where I think the discussion happens, or is at least happening for us, is in the postmenopausal women. Because in that subset, they showed no benefit to chemotherapy when they looked at 5-year IDFS. And so the absolute difference in distance recurrence was 0.3%. They then sliced it a few ways. So remember, one of the stratifications was on recurrence score, so 0 to 13 and over 13. And once again, in both of those groups, there was no benefit to chemotherapy. They then looked at number of nodes, so 1 node versus 2 to 3 nodes. Once again, no benefit to chemotherapy in postmenopausal women. Now, this has led us to have a little bit of conversation because our clinical practice was in a patient with clinically node-positive disease that showed up in my clinic. I immediately started talking to them about neoadjuvant chemotherapy, sometimes neoadjuvant endocrine therapy. We made sure there was a clip in the node, and we started having these discussions. But if there's no benefit to chemotherapy, we may have to rethink that paradigm. We still need some data, though, to really evaluate that. So in the trial, we really don't have data from what was presented on were these clinically versus surgically diagnosed axillary disease. So are these patients who had nodal disease identified on an ultrasound versus and may have had 1 or 2 centimeter metastatic focus versus patients who had a single 2.4 millimeter node identified at surgery. And so we do know that in 37% they had sentinel node dissection alone. But once again, we can't know for sure that those axillary node dissection patients were identified preoperatively. And then there's the distribution of the number of positive nodes. When we looked at this when Axilla 11 came out, and there was this question of what do you do with that preoperative ultrasound? Should we be performing a preoperative ultrasound? Because if we find a node, that means they need a node dissection by the standards. And we looked at patients who had 1 or 2 suspicious axillary nodes seen on ultrasound, and that's with a biopsy confirming positive disease, versus those who had no nodal disease identified on ultrasound and were found to have it by sentinel node dissection alone. And what we saw was that at least a third of the patients who had only 1 or 2 nodes seen on ultrasound were going to have more than 3 nodes when you actually did their surgery. And we also said that the focus was much larger than if you had nodal disease identified by a sentinel node dissection. So I think this is an area of debate. Like I said, we're actually scheduling a multidisciplinary meeting to talk about it because we know that that a proportion of those patients will have more than 3 positive nodes when we actually do their surgery. We know from SABCS2021 that in ER positive patients, 20% of them can convert to node negative after neoadjuvant chemotherapy. So we've got to figure out how to balance these patients. Do we give them chemotherapy in hopes that we might be able to omit an axillary lymph node dissection if they converted to node negative? Or do we say, we don't think there's going to be a benefit to chemotherapy and we're going to go ahead and perform an axillary lymph node dissection and hope that they have small volume of disease and we can avoid chemotherapy? I think that's going to be a really hard discussion and really hard decision tree for everybody. So in conclusion, some of the things discussed at San Antonio Breast this year. So in clinically node negative patients, management of sentinel node positive patients, I think the SYNODAR 1 trial shows us that it's okay to omit axillary lymph node dissection in patients with macrometastasis identified by sentinel node. Once again, this doesn't answer the question of patients who had clinically node positive disease found on ultrasound. But if you don't see it on ultrasound and you find it on sentinel node dissection, I think that their data supports omitting axillary lymph node dissection. I think the what to do with elderly patients is still something that we have to all discuss. I think it's okay to consider omission of sentinel node dissection. We know if you do a sentinel node dissection, you may be committing them to more adjuvant therapy. We just don't know if that adjuvant therapy helps. In clinically node positive patients, I'm still going to stand by my stance that the clip node improves axillary staging after neoadjuvant chemotherapy. And I think the outcomes with omission of axillary lymph node dissection in those patients is still being evaluated. And then the impact of responder, I think, is really still to be determined. And with that, I would like to thank you and open the floor for any questions. I'm going to stop my share screen.
All right. Well, thank you. That was an excellent talk, and the issues around responder are interesting. I hadn't really thought that through in that way yet. So we do have some questions from the audience. Can you comment on how these trials determined an acceptable false negative rate of 10%? Is there a real any evidence base for that 10%, or was it kind of just an arbitrary, we're willing to accept 1 in 10 women?
I think it was related to the data on clinically node negative patients that showed a false negative rate of 8 to 9%. And I think also given that these patients were all going to get radiation afterwards. So I was not a part of those discussions, but that's what I would guess. And if I remember reading the protocol, there was some language around that.
And
I have
what's
in the private chat, if it's okay, I think that everybody might want to
oh
know
yeah, please.
about the consequence of missing a pathologically positive node. I think that's a great question. When we look at our data and our false negative results, what has been missed has been very, very small, like 1 millimeter, 2 millimeters. And one of the false negatives that we reported, it was a 0.2 millimeter met found in the lymphatic channel outside of the node. So very small volume disease. All of those patients receive radiation. I think that Alliance 11202, remember that's the trial that looks at clinically node positive patients get chemotherapy and have a residual positive node after chemotherapy. And those patients are being randomized to axillary lymph node dissection or not. I think that trial is going to give us a lot of results, because if it shows us that completing an axillary lymph node dissection may not benefit all patients, that might make us all feel a little bit more comfortable about if we missed a very small volume disease.
And does your group in clinical practice have a number of ultrasound or MRI detected nodes at which you say this person's not a candidate for targeted axillary dissection?
We do. We are only offering it to patients who are clinically T1, T2 tumors who have less than 4 suspicious nodes on their initial ultrasound. And the reason for this is that as we've expanded our data set, and we've reported it at SSO, but it hasn't been published because we're trying to get a little bit more data. And those T1, T2 clinically with less than 4 suspicious nodes, we had no false negative results in about 200 patients. So we feel really strongly that the false negative rate in that group is really low. In patients who had 4 or more suspicious nodes, we had a really small sample size, about 80 patients, but the false negative rate looked to be about 8% with a pretty wide confidence interval. So we didn't feel comfortable that we could accurately assess whether those patients had a complete nodal response. I'm going to add one more element to that, we know that patients who have 4 or more clinically involved nodes, those are the ones that benefit from surgery with additions of radiation. And so not only may targeted axillary dissection might not be as accurate in those patients, but I also personally worry about that they're at higher risk for recurrence, and it may not be the group that we should be de-escalating care on. But we're continuing to collect that data to help get a little bit more guidance.
All right, well, excellent presentation. We're having some people having issues with audio. If you are also having, we'll check and make sure the audio is working. If you're also having audio issues, if you want to just comment in the chat and let us know, that'd be helpful.
We're
right,
also
well, thank you, Dr.
recording these, and we'll post them on our website as well. And so in case you missed anything, you can always review. I know that that's not the best, and we'll try to see what's going on.
All right, well, thank you for a great talk. Wish you the best.
Thank you for inviting me. Next time we'll do it in person.
Thank you, Dr. Cottle from